now move on to the first keynote of the day. And it gives me great pleasure to introduce our keynote speaker. Kirsten Bibbins-Domingo, as you heard, is the inaugural Vice Dean for Population Health and Health Equity at UCSF. She's also the new chair of the Department of Epidemiology and Biostatistics. Kirsten is a prolific researcher and publisher, no surprise there, with a focus on cardiovascular disease, including the Cardiovascular Disease Policy Model, or CVD Policy Model, which has been very influential. She has started the Center for Vulnerable Populations in 2006. She has been a wonderful presence at this campus for all these years, and now a much more prominent presence. We're very happy to see you elevated to these positions now to take your message more broadly, and we hope that today helps you with that message. Thank you very much for coming.
Thank you very much. It's a real privilege and honor to be here today with all of you. This is one of my favorite meetings. I'll start with the lesson, though. So in the program, the title of my talk is The Compelling Economics of Improving the Health of Vulnerable Populations. I was really thrilled when Dr. Kazi asked me to speak, really horrified when I ignored his email to give him a title, and that's what he left me with. I'm a little terrified of health economists in general, but the idea of making a compelling economic case to a group of health economists is, a little daunting. So, but what I appreciate about this meeting every year is exactly what Carol said, is really the multidisciplinary nature, the fact that we have economists and epidemiologists and physicians and in the room talking about important issues, I think is probably the most compelling aspect of this meeting for me. And for thinking about the case for vulnerable populations, I think it does require a multidisciplinary approach. You already heard from Dr. Seligman this morning talking about the economic case for SNAP benefits, but then really that isn't the reason of SNAP benefits is not to save healthcare costs, right? And so how do we think about what metrics we're using? So I offer 5 thoughts today about how we frame our discussions about vulnerability and the economic case for a focus on vulnerable populations, and what it means for the types of interventions that we choose to pursue. So let's talk about what is vulnerability. So I'm going to use this sort of simple definition that vulnerability is what puts you at risk when there's a mismatch of the resources available to an individual in a community and the life challenges that they face. So this is now to flesh this out a little bit more. So vulnerability, the susceptibility to harm, results from an interaction between resources that are available and the challenges. These might be a variety of different types of resources that are available, types of ways in which an individual or community can be disadvantaged, and how those things interact over time. It's a broad definition, and when Dean Schillinger founded the Center for Vulnerable Populations and I joined him, we struggled a little bit with whether we should call this the Center for Vulnerable Populations. And I have to say it's one of the choices that I'm most happy with because this very broad definition, I think, has in fact allowed many people to come into the room to discuss what it means to be vulnerable and how that impacts health. So let's flesh this out a little bit more. So who are vulnerable individuals and communities? So all of us, as Dr. Kazi said at the beginning, have periods of vulnerability. This is made clear. My colleagues who do work in the hospital say, when a person is hospitalized, that person is vulnerable. They lose control. They lose connection to their usual social networks. There are many aspects that make that individual, who in any other context wouldn't be considered vulnerable, particularly vulnerable. And one might argue that having such a broad, expansive definition is not useful. I think it actually is, because it allows all of us to appreciate those periods of vulnerability and what that means for how we think about our own health and decision making. The groups we're talking about, though, of course, are persistently vulnerable. They don't have these episodes of vulnerability. They have periods. They have vulnerability over long, extended periods of time, right? So let's also note that vulnerability is not an innate characteristic, nor is it the sole characteristic that will define an individual and community. And I think this is also critically important, because as much as we talk about vulnerability, understanding those aspects of resiliency in individuals and communities is just as important. And because the interventions that we talk about, many of them actually leverage those aspects of resiliency within populations to actually think about how one might improve health. And then lastly, just to note that vulnerabilities vary across conditions and across contexts. So what might make an individual or community vulnerable in across a particular disease access or in a particular national context might not make that same individual or community vulnerable as well. So just thinking about all of those things, because we are now trying to talk about vulnerability in a global context, but obviously each national context is very different. And if we look even in the US, let's take life expectancy as a measure. Here's a look at counties. This is 2012, looking at the range of life expectancy, which vary widely across the US, which in general has, a pretty good life expectancy. Of course, as all of you know, though, life expectancy that's in fact declining, right? And you see here your eye is drawn to areas that have shortest life expectancy in the south. If we were to update this map, you would continue to see rural areas. As we know, there's a lot of attention now to rural areas and the lower life expectancy. That's because of the opioid epidemic and other types of diseases of despair, as they've become known, really giving you a sense of the variability across the US. We in the Bay Area, of course, right there in blue, but in the Bay Area, let's remind ourselves that this is what the BART map looks like. So the gap in life expectancy between Oakland city center and Walnut Creek is also a 10-year gap, right? So in the Bay Area, although we're in blue, this is the map of the Bay Area. So context matters, how we think about individuals matters, and how we think about communities matter, because vulnerability is really is something that is highly then dependent on context. So even though I've given you an expansive definition of vulnerability, that it's sort of fluid, we can all be vulnerable, it varies from population to population, it varies from social context, I want us to really fall back on the social epidemiology literature to really understand the fundamental causes, the things that are sort of the most upstream that probably are true across multiple types of societies, right? And so this is the work of Lincoln Phelan, who many of you who are familiar with the social epidemiology literature will know. They were interested in understanding or commenting on the fact that it is not just risk, but that there are individuals and communities who are at higher risk of risks, right? And so to think about what are those most upstream factors that really place a population at risk. So they developed this fundamental cause theory, and the fundamental cause of health inequities, as they described it, should meet 4 criteria. That it should influence multiple disease outcomes, it should affect these multiple disease outcomes through multiple risk factors, it should involve access to resources that could be used to avoid risk or minimize the consequence of disease, and that the association should be reproduced over time via replacement of intervening mechanisms. And this set of criteria then led them to define socioeconomic status as the fundamental cause. And this is a fundamental cause theory. And so I want us to just keep that in mind then across the populations, the societies, the nations that we're talking about, a socioeconomic status as a fundamental cause of the types of health inequities that we're talking about. So, and then stated more, fleshed out a little bit more, that regardless of disease or context, high socioeconomic individuals and groups can flexibly deploy resources to avoid risk and to mitigate the effects of poor health. And resources are not just money, they're also power, knowledge, prestige, and social connections, right? And so this concept, which they developed within the US concept, is something that should resonate, I think, across different national contexts. So just to flesh this out a little bit more, when it comes to infectious diseases, those of higher socioeconomic status can avoid areas that carry risk of contamination. They can limit the entry of potentially infectious individuals, right? That's one strategy we can use to protect ourselves in the US as a higher income country. With cardiovascular disease, you already heard that higher socioeconomic status individuals have access to healthy foods and that they live in communities that can facilitate healthy choices. And in all contexts, socioeconomic status is related to access to quality medical care. The initial theory of fundamental cause really focused only on socioeconomic status, and there was much debate in the literature about racial and ethnic disparities, and these were, there's a lot of debate in the literature, and initially the theory developed within this fundamental cause is that race-ethnic disparities are collinear with socioeconomic status. So in a paper published in 2015, Lincoln Phelan argued that socioeconomic status is itself also a fundamental cause. And it is predictive of SES, itself a fundamental cause, but that independently, both through individually mediated racism, but then through structural racism, racism itself is a fundamental cause. Remember, they're writing in the US context, and so in the US context, this makes sense. How this translates to other national contexts, I think one has to think about stigmatized populations and populations subjected to systematic discrimination, and I think in other national contexts can also reason these as fundamental causes. So the first point I want you to appreciate is that vulnerability, I think, is a very useful context to think about many ways across many axes that individuals, communities, populations are vulnerable to poor health. It allows us to communicate across multiple types of societies for very similar issues, which I think has a big advantage. It is very flexible in that type of way of conceptualizing the problems we're talking about. And then I also want you to appreciate that factors like poverty and discrimination are upstream causes that translate across many of the contexts we're going to talk about. So the second point I want to make is that the choice to address the health of vulnerable populations ultimately reflects the values of a society. And I think it's worth saying that, because if we only want to make the economic argument, we're probably going to fall down quickly, because ultimately this depends on what we value, right? But I also want to make the case that there are several compelling factors that those of us who are concerned about health, who are concerned about economics, can approach this issue to continue to make the case for the health of vulnerable populations. So the most clear way in which you might answer the question, why should you in this room care? Although I've made the case we're all sort of vulnerable at different points in time, we're still, 4 major academic institutions that have come together to have this wonderful colloquium at Genentech Hall. So the aggregate vulnerability in this room is probably less than many other places. Let's just acknowledge that, right? So what is the case for us? So why should we care about it? So one of the clearest cases is probably in the areas of infectious diseases, right? The borders know no bounds for containing infectious diseases, and even though I already said we can close our borders selectively to try to keep infections out, the cases like Ebola and Zika remind us that those things are not as easy as we think they are, right? And I think if you look and start to tease apart those most recent epidemics, and Ebola, I think, is an excellent example, it highlights that if one were to try to understand what factors led to the rise of Ebola and what individuals one would target to try to stem this epidemic, one would really have to pay close attention to social vulnerabilities. And this is a map that in rural Liberia basically is overlaying the new cases of Ebola, the distance to medical care, and then clusters of different types of social vulnerability. And you can see that this isn't just a case of rural places that had a long distance to medical care that defined why Ebola rose in those particular areas, there's a strong interaction between specific types of social vulnerabilities that also allowed Ebola to be more prevalent in those particular areas. And it's the complex interplay of all of these that also led to probably the lag in being able to define that this epidemic was on the rise and how to intervene. So, understanding this from the perspective of controlling infections, I think is critical and is the most clear. Let's think about the non-communicable diseases. So these are slides from what the obesity and diabetes metabolic epidemic in the US looks like. And there's a strong relationship between the income, the median income of the counties and the rates of diabetes and obesity in those counties. And so to the extent that all of us will be caring for the higher rates of diabetes, understanding that diabetes is in this country a disease of poor and minority communities, in addition to many other communities, should lead us to think about what it will mean to try to intervene to stem this tide. Without understanding the links between poverty and minority status and the rise of these metabolic conditions, as Dr. Seligman talked about, it'll be more challenging to think about interventions. We've already talked about poverty and its link to poor health, and we know the arrow goes this way, but of course the arrow also goes this way, right? So poor health also leads to poverty. And if you are concerned about the economic development of a particular country, understanding this link, that it goes in both directions, is actually critical.
I'm having trouble with it.
Is actually critical. And I think for me, more as important as this is to really understand that the epidemiology of poor health in poor communities is often an epidemiology that starts in childhood, starts in adolescence and young adulthood, and really shifts where the burden of poor health is across the lifespan. And the economic consequences then are not just not just within this cycle, but that the burden of poor health is in the age group where one imagines to be the drivers of the economic vitality in a particular national context. So an example of this is work that we did looking at the burden, the consequences of the adolescent obesity epidemic over time. Adolescent obesity leading to more metabolic conditions as someone ages, leading to cardiovascular disease, diabetes, then in young adulthood and young midlife. And the consequences there are increasing healthcare costs because those people who usually are not going to the doctors are going to the doctors and having heart attacks. That's important, so they incur healthcare costs. But larger than the healthcare costs are the wages lost to premature death, as well as the wages lost to disability, right? So this is the time in life, this adolescent, young adult, young middle-age period where are the largest engines driving an economy. And so the burden of poor health in those ages is actually not just the healthcare cost burden, but the cost of lost wages and lost productivity. The time in life, though, of the young adulthood is also an opportunity for intervention. So breaking that cycle between poverty and poor health has the potential to actually have not only effects that magnify beyond that individual, as we're talking about here, but also magnify in the intergenerational effects. And that's why many of us are really interested in thinking about the impact here, both on the individual and communities, but also on the next generation. And then lastly, just to remind you of this slide that always has a lot of attention, that those countries among the high-income countries that have the greatest income inequality also have the worst health, worst indicators of health and social problems. And so the cause-effect here is complex, as you know, but it is worth pointing this out as well, and where the U.S. is on this map. So, several different ways one could look and to make the case of why we should care about the health of vulnerable populations, how it impacts our own health and the economics of our country or other national contexts. The next point I'd want to make is that addressing the health of vulnerable populations may require approaches that focus specifically on these populations. And this is going to be a theme I think you'll hear throughout the day, whether we need universal programs, better universal programs, or programs that specifically target the groups that we're talking about. And likely both approaches are needed, but I thought it'd be helpful to think about the conceptual frameworks that might help one decide. So this is the work of Froelich and Potvin, who basically pointed out the fallacy of our population-based approaches to intervention. So if we take an intervention that works, that has a change in the mean effect, one moves this distribution down to a lower level of risk after the intervention, but one doesn't, in this scenario, change the shape of these curves. So that individuals who are at the far right of this curve, who might be at higher risk, remain at higher risk. So the gap between high-risk populations and low-risk populations is exactly the same before and after this intervention, although everyone has improved, right? So whether you care about this depends on whether you care about the gap, right? So, and you might not care about the gap because everybody did get better in this particular scenario, right? I think whether you care about that there's a gap matters if your goal is to continue to eradicate this particular condition, because now you'll have to focus on people here at the tails. And so it might lead you to then target resources differently. But this, just to note that even in good interventions that work, that if the distribution of the population affected by this particular intervention, if the shape of this distribution doesn't change, it's likely that the gaps in health are unlikely to change. Probably more concerning and more important is the potential that interventions actually worsen inequities, right? So if the concept is that vulnerability is about a mismatch between resources and the thing life throws at you, then interventions that rely on those resources, either knowledge, access to care, other types of things, it is possible that the shape of the curve actually worsens, and worsens in a way that concentrates risks in one group and actually concentrates benefits in another group, right? That this worsens. And so does this actually happen, or is this just some super smart theorist postulating these? So there is evidence that this happens, and we can go back to the work of Link and Phelan and actually look at some of the empiric examples that they use to justify their fundamental cause. And reviewing this is always like, it's always like shocking to me when I do this. So it turns out in the 50s, everybody smoked. And literally everybody smoked. There was no gap by whether you were rich or poor. Every single person smoked. Really high rates there, 50%, right? As we started to understand the link between smoking and cancer, this is when the gradient started to develop here, such that now poor people smoke and rich people don't smoke, right? This happened over time, and the work of these colleagues basically, of these investigators basically shows that this parallels sort of knowledge about the link between tobacco and cancer, and they don't do a lot of work paralleling the types of medical interventions, but certainly parallels knowledge. So this gradient in tobacco, which we've come to accept that poor people smoke and rich people don't smoke, is one that we've come to accept, but isn't one that existed just several decades ago. Does this matter for health? Well, it turns out it does, right? So if we look now at the consequences of lung cancer mortality, in the 50s, it was high SES people who died of lung cancer, low SES people didn't, and then you see this shift, right? So not paying attention to this underlying vulnerability framework sort of has in fact at least contributed to this gradient in the way that we see the smoking patterns, and then the consequences develop. How do we think about this in other contexts? So internationally, we think a lot about childhood mortality. And what you see here is that countries vary by their rates of under 5 mortality, vary quite substantially across varying national contexts. But within each context, poor individuals have higher rates of under 5 mortality. And this bulletin very nicely outlines several points. The first is that interventions within these contexts, many of these actually worsen the gap between the rich and the poor in terms of childhood mortality when they're first introduced. They make the second point that it's not inevitable that some of the most sustained and intensive interventions have actually led to closing of the gap. But the third and probably most compelling point to me is that if we are to actually improve rates of under 5 mortality, we are left with really focusing on the poor populations in all of these countries, right? The numbers that are left where, where there is ability to make an impact is still in those most vulnerable groups. And that is, of course, back to the smoking example, true of smoking as well. So our wonderful both population-wide interventions for tobacco control as well as our individually targeted interventions, now the pattern likely has to shift so that we reach those remaining communities that are still smoking at high rates. And the question is whether the same types of strategies will be able to reach those communities. Of course, when you say that, in general, gaps don't close, or gaps can widen, there's always a nice exception that proves your rule. And this nice exception comes from our keynote speaker this afternoon, Ashish Jha. I don't know if Ashish is here. But this was published in Health Affairs and looks at the postoperative mortality rates. There have been very intensive efforts nationally to improve postoperative mortality. And as you can see, there have been dramatic declines in postoperative mortality as a result, and interestingly, a closing of the gap between black-white mortality postoperatively. This is very nice work. Ashish's group shows here that this is not just because blacks are going to other hospitals, but actually within a hospital, there's been improvements between mortality rates, between this gap between blacks and whites. But I think this is also, in some ways, an exception that proves the rule, right? This is a highly intensive national effort to improve surgical mortality. That was really a buy-in from all of the organizations involved. It was really quite intensive across the hospitals, and did certainly lead to this closing in the gap. And I think one has to wonder, especially if you see this slight uptick again, is like how much more one needs to actually continue to close that gap over time. So let me go to point number 4. So point number 3 is that we might need to focus specifically on vulnerable populations in some way, that failing to do this might mean that the gaps persist, but probably more importantly that the gaps worsen. Point number 4 is that vulnerabilities cluster. And that should be evident to you from just our definitions from the very beginning. But the fact that they cluster also limits the effectiveness of interventions that we might design, especially because the way we tend to make design interventions focus on a particular disease and that or a specific risk factor. And so I'll bring you again to the maps of San Francisco. This is the rates of hospitalizations in San Francisco by neighborhood. This is an area that I work on and many of us in the Center for Vulnerable Populations work on. This is the percent of mothers receiving prenatal care, and you're focused on the reds and orange, which tend to live on the right side of the map, and the greens, which are better, live on the left side of the map. And you see the same pattern if you look at age-adjusted preventable hospitalizations, which of course also live on the right side of the map, and then the better rates live on the left side of the map. And then if you overlay violent crime statistics, you see a very similar pattern. And so the point is that these very important conditions that each of us in our own centers, hospital units, clinics, research are focused on are actually affecting, of course, the very same communities, right? And this was made clear to me when I was working with my colleague who has designed a really wonderful, innovative trauma wraparound program to prevent victims of trauma from becoming repeat victims of trauma trauma, who said to me that her biggest challenge is getting the mothers of these victims to come to the appointments because they have to take care of their diabetes, right? So I'm working in my diabetes silo, and she's working in her violent crimes silo, and this is the same communities, right? And so I think that so thinking about how our standard approaches are in fact limiting the very groups that we're trying to help is I think fundamental to understanding what we could do better. And just to make the point that, that on the global context, vertically designed programs that really go soup to nuts across a particular condition, is in fact a highly efficient way to do something in a resource-limited setting. But as you can see, if you, that this approach, when one considers the same types of underlying vulnerabilities in a community, may in fact be the most challenging. And I think this is one of the biggest challenges facing how we address the global rise in non-communicable diseases that in fact have vulnerability sort of baked right into them and are affecting a much larger portion of the population. So the last point that I would make is that the growing need and inherent challenge in current approaches to addressing health in vulnerable populations is what's leading more and more people to consider upstream factors and assuring scalability and reach of their interventions. And so I want to, if you haven't been reading the New England Journal of Medicine or JAMA or papers in major cities like Boston, you're maybe missing these headlines. And these headlines are all about academic medical centers stepping right into the housing game, right? And I remind you, these are, you'll hear from my colleague Margot Kuchel in the afternoon, the issues and the way in which several hospitals, health systems have stepped directly into addressing housing is really quite striking, and I think reflects the fact that we are at a point in time where it appears that addressing the upstream factors that are contributors to multiple health conditions is the most effective approach that we can take at this particular time. And several hospitals are actually taking that, and I'm sure you'll hear from Margot this afternoon about why that is and what are the strategies for doing that. I'll remind you, these are several articles published in JAMA and the New England Journal, not the Journal of Poor and Underserved. So this is something that all of us will be thinking about within our own health settings. There's also a big move for hospitals as anchor institutions, recognizing that hospitals themselves are economic actors within a community, that if we're trying to address the inequities within a community, they have many levers to pull. They are both purchasers and real estate developers, so not just giving money, but they could in fact be doing this. And you see this, you see several health institutions within smaller urban settings actually taking this role. They are parts of workforce development and, of course, conveners. And I think this movement and how it is playing out across multiple hospitals is also in direct response to the concern that it is very hard to address the health needs of many in our community without a focus on these upstream factors. Some are doing this not in as sort of bold ways, and so for many there's an interest in really just trying to understand how social and behavioral determinants of health impact a particular patient we have in front of us or a particular panel of patients we're trying to manage. And this is an Institute of Medicine report led by Nancy Adler here on how one might do this in the electronic health records. And that committee came up with 10 domains that are sort of shovel ready to be able to put in the electronic health record, that have a linked intervention that is evidence-based, that knowing this particular intervention might help you to care for a patient or a set of patients better. And I think that there's a lot of discussion on how we might do this better within the context of a healthcare setting. This is work from my colleagues in Cincinnati who geocoded all of their health records in Children's Hospital, Cincinnati Children's. They were interested in asking the question, how do we reduce readmissions for asthma? And geocoding their data led them to see that, well, yeah, the children who are being readmitted for asthma all live in a certain place. But not only that did they live in a certain area of town, many of them lived in one particular apartment complex. And so they realized as a hospital that intervening on that particular apartment complex was probably the most efficient way that they could actually intervene on the asthma readmissions, and that's what they do. And as a result of this particular experience, they now have a set of questions that happen upon screening that answers yes to any of those questions automatically generates a medical legal referral form because of the idea that their role is to not ignore these social determinants, but actually to play a part in at least linking for intervention. Nationally, I think it's the rise, internationally, globally, it's the rising tide of non-communicable diseases that will continue to force this issue, because I think globally we are talking about the rise of conditions that themselves cost a lot of money and are rising in countries that do not have a healthcare infrastructure to deal with chronic diseases that cost a lot of money. And so I think this is leading globally many to think about, well, what are the policy strategies that could help us think about prevention as not just one person at a time, but really sort of across the population. And this is a WHO report that came out last year really endorsing soda taxes and other types of fiscal policies to improve the diet globally, which is probably the most important factor in stemming the tide of these non-communicable diseases. And just to remind you that the soda tax in Mexico is actually the first country to adopt a soda tax on a national level, that the tax has been in many ways working as expected, sort of leading to declines in soda purchases and in greater declines among those of lower socioeconomic status, as you would expect an instrument like this to work. So in summary, and I'm looking forward to the discussion, this vulnerability framework that we're using today, I think, offers an approach to understanding health needs and health risk, an approach that allows us to talk across many different national contexts to understand those things that we need to improve the health of those who are at highest risk. Although vulnerability needs to be adapted to particular contexts and conditions, it's important to remember that poverty and discrimination probably underlie the vulnerabilities in most national contexts. The decision to focus on vulnerable populations reflects societal values. I think we have to acknowledge that, because if we only rely on the dollar sign to look better, it will not always look better. And I invite you to press your colleagues on that as you go throughout the day. But I think that the compelling case can be made to focus on these groups, particularly if the goal, as all of our goal is to improve health, and if we believe that improving health ultimately has economic consequences, economic benefits down the road. The challenges of addressing the needs of vulnerable groups is leading to an increased focus on upstream factors, and importantly, interventions that scale and reach the groups that we're trying to reach. All right. With that, I'm happy to entertain questions and discussion.
Hello. First of all, I just wanted to thank you for your talk. It was very inspiring and very interesting to me personally. And my question is regarding societal values. I think that's something that's not emphasized enough, because in my experience as a woman of Middle Eastern descent and interacting with people from that similar background, I remember once I had an Uber driver here in the city who told me that he found homelessness to be a mystery here, and he didn't understand why there were so many homeless people here in America, because in Afghanistan, which is where he's originally from, anybody who needed a place to stay would be able to stay with a stranger even, and they would take care of each other. And I just found that remarkably inspiring. And I'm just wondering how here in America we can kind of change the narrative of how homeless people are either crazy because of mental health issues, or that because they're addicted to substances such as opioids or whatever, that they aren't deserving of compassion and empathy and for other people to help them out. So I know that there are a lot of very negative stereotypes regarding vulnerable populations, whether they're lazy or they don't want to help themselves. So I'm curious to hear your thoughts on how we can start changing that narrative.
Yeah, thank you. I think that this is sort of at the crux of the issue. Sort of in my view, we have to be changing the narrative on all fronts. So I do think it is about using all of the medium we have at our disposal, right? Whether it is stories and individual stories that sometimes are more compelling. For some people, it will be the economic case, and that is what we're here to discuss today. And I do appreciate, when Hillary says sometimes that metric is what gets people's attention, right? I'm working on a study right now with a colleague at Yale on incarceration and health, looking at the cardiovascular disease consequences. And in some ways, I'm like, do we need to know that the higher LDL is the reason why multiple ins and outs of prison is bad for you? Maybe not. But if that's what gets other people interested and in the room talking about it, then that's fine. Because I think what we do need is more people in the room talking about the health needs. And sometimes it is the economics, sometimes it is particular health conditions that get people in the room, and sometimes it will be the stories,
Thanks. That was a great presentation. Thank you. I want to try to link some of what you talked about to our previous two speakers. And we see a lot of burden of disease or cost of illness numbers being thrown up, and we saw that with the food security and the SNAP program, what it can save. And I do think we need to think about what it will cost as well. So currently, I think half the U.S., the ag budget, or the SNAP, the Farm Bill, 50%, I guess, is on food stamps or SNAP. I'm not sure if that's correct or not. It's about 80%. So we're treating a problem and we're not preventing it. And so I want to just kind of, I don't have the answer. I think that in the case of sub-Saharan Africa, we're looking at prevention, but then the question is who pays. Mm-hmm. So I think we have to start thinking not just only about the cost to society. That's effective, but what is the prevention? Getting to your point, so I just want to throw that out there. I don't have any answers, but.
Yeah, I think you're exactly right, and I think I invite you when you have your panel on homelessness this afternoon to talk, right? So as Margot Kuchel will always say, that the fundamental cause of homelessness is lack of affordable housing, right? So we can do whatever we want to in terms of respite beds, assuring transitions, vouchers, but the fundamental cause has to do with these lack of affordable housing. I do think the economics, though, it's interesting to me that hospitals and health systems have been stepping into that housing place, because that feels probably the food in some ways is most, costs less, it's easier to make the investment, it's easiest to link to health. Housing is certainly related to health, but making investments in housing, this is what they're doing. It's very interesting to watch that happening, and it feels to me like we're at a point in time where there is an increasing awareness that really we need to look way upstream and be willing to invest. And I think the anchor institution piece is in particular in that light.
Yeah, thanks for that excellent talk. So getting to your point about these sort of vertical health problems that are being addressed by sort of fundamental causes like poverty, food insecurity, racial discrimination, one of the challenges, so both from a programmatic perspective, we're treating them separately rather than integrating to some extent, and then there's certainly movement to improve that. But from a research standpoint in particular, it's exceedingly challenging. So, and I know maybe Hillary faces this, I face this with our food insecurity interventions. It's like affecting people from development to increased rates of cardiovascular disease, to increased adolescent risk behavior, all the way to frailty and cognitive decline at every level. And your study is documenting, because of the way the funding bodies are organized, one particular health outcome, which then also, and then when you look at cost effectiveness, you're framing it. within certain health outcomes, but it's much, much broader. So I don't know if you have,
Yeah,
suggestions.
so on the one, I have three thoughts. On the one hand, I'm a pragmatist, right? So if getting the people who care about diabetes to care about food insecurity is the way, and then let's do that, right? On the other hand, I will say that that I think there's a risk. So one of the big concerns, of course, is that we've done so well with helping people live longer with HIV/AIDS that now we have. Somebody has measured their blood pressure, and they all are hypertensive, right? And some will develop metabolic conditions, and right. But designing programs to address non-communicable diseases along an HIV/AIDS model is potentially problematic, right? And so, while I appreciate when I'm asked to, consult on like what we can do in those areas, and I think that there's strategic opportunities to think about it, the concern that a model might have to look very different, I think is the risk, just as you're talking about. I do think, I do appreciate, and again, one of the things that I've long appreciated about the center that we've run is getting people in the room together who think about food insecurity or think about homelessness, and then we can think about it across multiple populations or across multiple conditions. And I think it will be, because I'm ultimately an optimist, is that it will be sort of those cross-disciplinary discussions that will actually sort of lead ultimately to better interventions.
Hi, Kirsten, that was really fun. As you were talking about this, and you put up that slide of the costs of adolescent obesity, it occurred to me that the first observation on that slide is that the non-medical costs are about 6 times the medical costs.
Yeah.
But the problem in society is that these non-medical costs are invisible. We don't see them.
Right.
And yet the healthcare costs, someone is documenting, someone is doing the accounting, which is why I think the investment in homelessness is as much as we think that these medical centers are doing it out of some form of largesse and concern about social determinants, it's really because they're getting penalized for all the readmissions, that they're willing to rechannel some of that money.
Yeah.
So, as someone who spent a lot of time thinking about those non-medical costs, I've begun to realize that no one cares. The costs that matter are those healthcare costs, because someone is going to respond to those signals in society. On that very uplifting note, my question actually, it was about this idea. I mean, I've heard you use the term of precision population medicine, and can you help us think about? Yes, we need to think about population health, but we also want to be targeted. Is there a way to reconcile those two concepts?
Yeah, so just on your first point, let me just say briefly, and I don't know if Margot is in the room, but you will be having conversations with her this afternoon. The interesting thing she brings up all the time is that while that might be a motivation, like most of those interventions that address homelessness don't save money, and they won't do that. And so, and that's pretty clear. And so even that headline that I put up there is actually a misleading headline of the very study that it's actually talking about. And so I think while if that is in fact the motivation, the short-term economic gains are not going to play themselves out. And I think that's been pretty clearly demonstrated. So I do think that there are many reasons hospitals are doing it, and so I think, and I don't think they always know why they're doing it, but so I think it's an interesting time and opportunity. The precision population health, precision public health, for me is how we use the data that's available to us on a population level to think about better ways of understanding complex phenomenon and better ways to deciding how to intervene. And so it doesn't replace the sort of values of deciding what you want to intervene on. It doesn't replace it doesn't replace a lot of things, but I think there are opportunities for complex phenomenon that do involve interactions across multiple domains to help communities, countries make decisions, because we ultimately have to make decisions. And I think the challenge with vulnerability across these multiple axes is that we're sometimes not using all of the data that's available us to figure out how to make the most appropriate health decision, even on a population health level. And I think the data and an understanding of the complexities of these health problems will hopefully help.
Kirsten, what do you think our responsibility as people in health thinking about vulnerability is to address the profound and increasing income and wealth inequality in our country and other places?
I see, an easy question. Well, I think that we have, so I think we have to address it. So I think that our job as academics is to speak the truth to what the numbers are telling us, right? So that even if we are designing interventions that might only be sort of the one-off first available thing for us to do, I think failing to talk about these larger issues is that we have sort of we have neglected our obligation, because the links are so clear. They're so clear across national contexts. They're so clear in the way we design interventions. It's so clear that each of the wonderful interventions we are going to talk about will only have success that to the degree that to the degree of their immediate impact. But I personally, and so I think we have to be willing to have the hard conversations amongst ourselves as we are today. Again, I am a pragmatist, so I don't mind if dollar signs are what get people in the door. I don't mind putting dollar signs in front of them for issues that are ultimately how we put, issues ultimately of value. But I do think we have an obligation to keep asking the hard questions, and those are about the income inequalities that you're talking about.
Thank you so much for sharing your insights. I'm Lou Garrison, University of Washington, Department of Pharmacy, health economist. A couple of terms you use I'd like to maybe just get some more thoughts on. One is societal values and also economic benefits. Mm-hmm. After having recently read Hillbilly Elegy and coming from that part of the country, I'm not sure, after the life of J.D. Vance, leading him to become a conservative or a Republican, surprised me, having seen so much inequity there. But so what are I don't think we have a consensus on societal values in this country, especially at the moment. What they are, I'm not even sure. And the second point, I feel like you're not being that precise in the use of the term economic benefits, because like Drew was saying, when you put up the graph with all of the the monetized value of the disability over a lifetime, mm-hmm. to me that's a full economic analysis. So sometimes you're using economic benefits to mean like short-term hospital cost savings, when actually I think that analysis, and according to the second panel on cost effectiveness, we have Josh here, Josh Solomon, who's an author, much broader concept of economics that we try to monetize, yeah. or we try to estimate the value of all of those things. So they're all economic benefits to an economist. So just quibble about that.
Absolutely. See, this is why I don't want to talk to economists.
You don't have to respond.
Yes. So the issue of values, I think, is an absolutely a critical one, right? So it's the flip side of what Jim is asking, right? So the inequalities, and I think. Right, and I think the point underlying what you're saying is to say that there is a set of values that we have as a society that define how we as the U.S. make a decision, I think is being challenged every single day, right, just by watching the news in the morning. And I think that that the patterns that we have that really illustrate the groups that are vulnerable because of particular set of economic forces, policies, rural isolation, other things. I think we are just coming to grips with how we understand that. I think I say it because I do think that ultimately these are still about choices that one can do. One can create many types of frameworks where ignoring the problem is perfectly fine, right? If we decide that that's what we want to do. And I think so the reason I say values, I don't mean to say that we have a shared set of values. I'm just saying that it is deciding to do something as opposed to something else that ultimately is what determines whether we will focus on vulnerable populations. And yes, I totally agree with you. I think you can make the case for an economic benefit if you take this larger view. I feel a little bit aligned with my colleague, Dr. Kazi, who says, do people really care, right? If that is for some people, for you, you look at that and that is a compelling economic argument, and I think for a lot of people, it's not. And that's why I've probably backpedaled a little bit, because I think for many people they're looking at the economic argument, meaning if we invest in food, then people will have less diabetes, right? And that I think risks not playing out the way we want to over time.
Kirsten, I really appreciate this. It's fabulous. And I'd like to take actually Dr. Kazi's remark one step further and say that when I saw the tobacco slide that you put up, yes, there was certainly like a knowledge deficit, but of course one of the first things that came to my mind is the targeting of minority communities by the tobacco companies. Yeah. And so I'm actually wondering if we take it kind of one step further and whether people are doing analyses of exactly who benefits economically off of these disparities. Because in housing and gentrification and sort of corporate policies around gentrification, in big soda and that world, in agribusiness, in tobacco, people are actually benefiting off of the disparities, and I'm wondering if those factors are being analyzed carefully of like who is actually standing to benefit by worsening these disparities.
Yeah, thanks so much for bringing up that really critical point. So we've portrayed these inequalities that they don't represent the fact that somebody continues to gain from the fact that there are these inequalities, right? And I think that is such a crucial point to understand. So the tobacco, as you said, it's not just a lack of knowledge or lack of access to medical care to stop smoking. It is the fact that over time then there's specific targeting of those populations. I do think that I do think it again, all of these questions about the sort of the economics in this situation depends on sort of the frame that you have, the perspective that you have about what we as a society value because somebody is making money off of the inequalities. I am sort of intrigued by the fact of the fiscal policies that have been put in place that people are talking about, whether they're incentives for fruits and vegetables or they're disincentives for tobacco or sodas or things like that, because they sort of sit right at the heart of somebody else's pocketbook who traditionally has been benefiting from a particular commodity that's not good for your health going to these communities. And I think that's where I would also love there to be more economic discussion, because the number of times, as I was just 2 days ago asked on a panel, of these taxes are regressive, are these things that are hurting poor communities, without the flip side talking about how poor health is in fact regressive, and the fact that industries continue to target particular communities and sort of contribute to what we see. It is an absolutely crucial economic element to continue to talk about in all of this.
Kirsten, thank you very much.
Great, thank you.